today's discussion on atrial septal defect. So good evening to all. So we have already discussed PDA in the last lecture. That was a eccentric congenital heart disease. And today we will discuss on atrial septal defect. This is also a cause of eccentric congenital heart disease. So we have already studied that there are different types of eccentric congenital heart disease. There are some shunt anomaly and there is no shunt. So eccentric congenital heart disease with shunt anomalies are atrial septal defect, ventricular septal defect, and PDA. We have already discussed atrial patent arteriosus, and today we will discuss atrial septal defect, and on of next lecture we will discuss inshallah ventricular septal defect. And there are some other common eccentric congenital heart disease where there is a no shunt, but those are the congenital eccentric heart disease, like coarctation of the aorta, congenital aortic stenosis. There are maybe pulmonary stenosis or tricuspid stenosis. There is a stents anomaly and dextrocardia. And in these cases, usually there is no shunt, but they usually produce a eccentric type of congenital heart disease. So now today discusses about atrial septal defect. We all know that the defect lies in the atrial septum. So there is a shunt, that is there is a foramina or there is an abnormal communication between the two atria at the level of the septal level. So there is atrial septal defect. So this defect lies in the defined portions of the atrial septum, interatrial septum. The defect lies in the mid part, that is called a second type of lesion, that maybe lies in the lower portion of the interatrial septum, and may involve the atrioventricular valve also, that is called primum type of atrial septal defect. And there may be some other types like venous type. In that cases, the defect lies near to the superior vena cava or inferior vena cava. So that is called venous type of atrial septal defect. So among these different types of atrial septal defect, second type is the most common type. It is around 80%, and it is located around the fossa ovalis and its surroundings. And primum septum defect is around the 15%. This is another called partial atrioventricular septal defect, AVSD, and it is located in the lower part of the interatrial septum, and the atrioventricular valves may be involved, and there may be a cleft mitral leaflet, that may be a mitral valve also involved, and there may be cleft mitral leaflet. Superior vena sinus venosus type may be 5%, and inferior sinus venosus type is 1%, is located near the inferior vena cava, and superior sinus venosus type located near to the superior vena cava. That is where superior vena cava arises, or the superior vena cava drains. And there may be unroofed coronary sinus type of varieties around 1%. Is separated from the left atrium, can be partially or completely missing. So these are the different types of atrial septal defect. We'll now discussed in a nutshell or in a bird's eye view, that is atrial septal defect. This person is the clinical findings, and we'll discuss this. So there may be some association, or there may be some causes of atrial septal defect. So there may be some genetic causes. So these causes may be some genetic mutations, or there may be some spontaneous causes, or there may be associated ASD associated with some syndromes like Holt-Oram syndrome, Treacher-Collins syndrome, or Down syndrome. In case of Down syndrome, usually a primum type, apicanal type of defect, that is ASD primum type is common in case of Brown syndrome. And in that case of VSD also common. And when there is a atrial septal defect, so there is a shunting of blood from the left atrium to the right atrium. As we all know that there is a increased pressure in the left atrium than right atrium. So blood flows from the left atrium to the right atrium, from high pressure bed to low pressure bed. There is a shunting. And as there is a shunting of blood from the high pressure bed to low pressure bed, and the shunting also depends on the between the pressure difference and also the size of the shunt. Size of the shunt depends on if there is a large shunt or the large size, there will be a large amount of blood will be shunted. So in that case, patient usually presents in the early, and if there is a small shunt, there is a small foramina in the atrial septum, patient will usually present in the latter part of their life, is maybe in the after 40 years. So this due to shunting of the blood from the left atrium to the right atrium, there is increased flow in the right side of the heart, that is in the right atrium, that blood goes through the right ventricle. From right ventricle, that blood goes to the right atrium, sorry, pulmonary artery, and from pulmonary artery, the blood goes into the lungs. So there is an increased pulmonary vasculature. This increased pulmonary vasculature usually lead to the development of the pulmonary hypertension, the latter one. And if there is a development of the pulmonary hypertension, so there will be the increased pressure on the right side of the heart. So there will be pressure increases in the right ventricle, also the right atrium. When there is a increased pressure in the right atrium, when there is equalization of the pressure between the left atrium, right atrium, or when there is a increased pressure in the right atrium than the left atrium, so there will be reversal of the shunt. That is, in that cases, blood also flow from the right atrium to the left atrium instead of left atrium to right atrium. So in that cases, we will call the Eisenmenger syndrome, and there may be a mixing of the deoxygenated blood with oxygenated blood. So in the body, oxygen saturation will be reduced. So patient develop clogging or cyanosis in the distal part. So actually, these are the pathogenesis and the atrial septal defect. So how usually atrial septal defect patient usually present? Patient will remain asymptomatic for a prolonged period in case of atrial septal defect. But when there is a large shunt or there is a foramina is a large, patient may usually present in the earlier part. Or patient may be asymptomatic for the prolonged period. Even up to their middle age, patient remain asymptomatic, and after 40 or 50 years, patient may be symptomatic. So one patient is symptomatic. So what are the other presentation? Patient may present with shortness of breath, or patient may present with palpitation and exertion. And when there is a actually there is a pressure rises in the right side of the heart, there is a development of the pulmonary hypertension. In that case, a patient may present with shortness of breath on exertion, or patient may present with palpitations also. Or patient may present with complications like Eisenmenger syndrome. In that cases, in the late part of the life, patient may present with cyanosis or clogging. In that case, a patient usually experiences severe shortness of breath. Even in a mild exertion patient may develop severe symptoms of life. So usually these are the presentations how ASD patient usually presents. So in a short, usually ASD patient may be asymptomatic, or patient may present with shortness of breath or palpitations on exertion, or in the when there is a Eisenmenger syndrome develops. In that case, patient may present with shortness of breath even with mild exertion, and patient usually present with cyanosis and clogging. So usually these are the presentation. And in the childhood, usually how ASD patient usually present. In that cases, patient usually present with repeated respiratory infections, as there is increased pulmonary blood flow. Also patient usually present with respiratory infections, and if there is a shunt is large, in that cases, patient may fail to thrive. There is a delayed growth of the patient, and may occur, or our patient may experience easy fatigueness in their early life. So what are the clinical findings actually we will get when patient come with atrial septal? There is actually no pulse, but on auscultation, what is the findings? On auscultation, usually there is a first heart sound usually normal, but second heart sound there is a definite some findings. As there is a pulmonary hypertension and develops, there is a pulmonary, as there is a right-sided flow increases, So there will be a delayed closure of the pulmonary valve in comparison to the aortic valve. That is, in that cases, there is a wide splitting of the second heart sound. That is pulmonary component, P2 component will be, there is a gap between the A2 and P2. That is the aortic component, pulmonary component, there is a gap. And this splitting is fixed usually, as there is no pressure difference between the atria and ventricle, as there is a phenomenon between the left atrium and right atrium, and usually there is a equalization of the pressure. So there is no difference in between the inspiration or expiration. And so the second heart sound, the splitting of the second heart sound is usually fixed. There is no variation with the respiration. So second heart sound is wide and fixed splitting of the second heart sound. That is a common presentation or common findings in case of atrial septal defect. And as there is increased flow between the from the left right atrium to the right ventricle, so there is a mid-diastolic murmur. There is a flow murmur actually. There is a mid-diastolic murmur we may get due to due to increased flow through the tricuspid valve. We may get mid-diastolic murmur, and also we can get mid-systolic ejection murmur. And usually this mid-systolic ejection murmur is due to this flow through the pulmonary vasopulmonary tree. And we may also get the features of pulmonary hypertension. That there is a due to pulmonary hypertension, usually there is a right ventricular enlargement. So right ventricular heaving may found, right ventricular heaving. So due to pulmonary hypertension and due to pulmonary hypertension, we also may get claving or cyanosis also. So this is the actual clinical features we may get during examination. And what are the investigations findings usually we get. And investigations, usually in ECG, we usually get right bundle branch block in the ASD. When a patient with right bundle branch block usually presents, so we know that there is a differential diagnosis of the right bundle branch block. One of the important differential diagnosis is ASD. So when we get ECG, right bundle branch block in ECG, we may have a strong suspicion that this patient may have atrial septal defect. Or in the case of atrial septal, if a patient will get atrial septal defect and we do ECG, we may get this patient may have right bundle branch block. So ECG we may get right bundle branch block. In X-ray, what are the findings usually we get? In X-ray, we may get cardiomegaly. We may get pulmonary conus is full due to development of the pulmonary hypertension, and or there is a bulging of the pulmonary conus. We may get there is a right pulmonary artery is enlarged and it is comma-shaped. We may get these findings. And as there is a increased vasculature, pulmonary vasculature is marking as prominent due to increased blood flow into the pulmonary vessels. And in the latter, when there is a pulmonary hypertension develops, in that cases we may get there is a Ollie-McLang-Field in case of pulmonary hypertension, severe pulmonary hypertension actually. So these are the X-ray findings, and on echocardiography, this is the gold standard investigations to diagnose the atrial septal defect. This is the function of the diagnosis. We may diagnose the type of ASD. We may diagnose by echocardiography and color Doppler, and we can differentiate the primary primum type, or we may differentiate the primum from secondum, or what is the sinus venosus type, or we may also diagnose what are the other findings along with the ASD. We can also diagnose by echocardiography. There may be a mitral cleft, mitral leaflet. There is a cleft in the mitral leaflet, so we can diagnose by echocardiography. And there may be total atrial pulmonary venous drainage, or partial PAPVD, partial non-pulmonary venous drainage. There is the abnormal communications between the pulmonary vein with the left atrium or right atrium. Usually pulmonary veins drain to the left atrium, but pulmonary vein instead of draining to the left atrium may drain into the right atrium. This may be associated with the atrial septal defect, especially sinus venosus type. So we may get diagnosis this type of pulmonary venous drainage anomalies by echocardiography and color Doppler also. So we make by echocardiography we can confirm the diagnosis of the ASD. We may confirm the type of ASD, and also we may get, if there is the other association and of ASD, we can also diagnosis by ASD. So these are the investigations like ECG, echocardiography, and chest X-ray. We can also use other modalities of diagnostic modalities like MRI of the heart, or we may MR, that's magnetic resonance, or we may also use the CT of the heart to diagnose definitely the different pathologies or different types of anomalies within the heart along with atrial septal defect. So actually these are the findings, these are the diagnostic modalities, and how actually will treatment the ASD. So now the treatment options, treatment in case of asymptomatic patient and there is a small ASD, usually no treatment is needed, and sometimes very small ASD can close spontaneously. And in case of treatment actually depends on type of ASD and the size of ASD also. This is a type of ASD. If there is a second time type of ASD, this is the most common type, around 80% of ASD. In case of 80% of the ASD, actually we can diagnose, we can treat this ASD, this variety by device therapy. I will show what type of device usually we use to close the ASD closer. Actually, this is the device closure. So in case of second time type, device closure is the actually treatment of choice. But in case of sinus venosus type, it may be supravenous type, infravenous type, or if there is a AV canal defect, that is a primum type of ASD, usually surgical closure or surgical treatment is the option in those cases. So in case of sinus venosus type or septum primum type, surgical closure is the treatment of choice. And in case of secondum type, the treatment of choice is actually septum, actually device closure is the treatment of choice. So actually in nutshell, these are the treatment, and when there is a patient very small type of ASD, in that case some medical treatment may be needed. And when patient develop severe pulmonary hypertension, in that cases when there is surgical treatment is not possible, or there is a device closure is very risky, in that cases we may only give medical treatment to reduce the pulmonary hypertension actually. In that cases, to reduce the pulmonary hypertension or to reduce the overload of the heart, we may use some diuretics, or may use for treating pulmonary hypertension. There are some drugs to treat the pulmonary hypertension. Different types of drugs, the prostaglandin receptor inhibitor or nasal receptor inhibitor. These are actually some drugs to reduce the pulmonary hypertension. So these are the actually drugs we can use when there is a severe pulmonary hypertension and when there is a surgical or intervention closure is not possible. So actually, these are the treatment option in this picture. What we will see here, that is different types of ASD variety. That is, this is the supravenous type. This is the infravenous type. This is sinus venosus type of ASD, and this defect lies in the first type of ASD second type. And this is the near to the actually AV canal or in the lower part of the septum. So this is the septum primum type of atrial septal defect. So these are the different types of atrial septal defect, and this classification usually depends on the site of foramina, site of communicating channel of this ASD. And it is the echocardiography where we see that there is a blood flow from the right atrium to the left atrium through the atrial septal defect. This is the flow from this flow, and this due to increased from left atrium to the right atrium actually. So this is the increased flow. There is a overload of the right atrium or right ventricle actually. And this is the pathophysiology I have already discussed. This is the diagnostic, how usually patient presents and what are the physical findings usually we get, and what is the investigational found, laboratory findings found actually get in case of ASD. And this is the treatment facilities we have already discussed. There is a surgical or there is a Parkinson's closure, that is a device closure. And usually we will do it when there is actually significant defects. And this significant defect depends on the symptoms, or if there is paresthesia, that the patient is symptomatic, and the dilation of the right V, that is volume overload sign. There is a significant shunt, that is QP/QS ratio is more than 1.5. And if there is a paradoxical emboli, and due to prevention of paradoxical embolism, and there is a planned pregnancy, we can do closure of the ASD. And Eisenmenger syndrome, there is usually there is a continuation of the closure. I have already discussed in case of Eisenmenger syndrome. Usually in that cases, we may treat the patient with medical treatment. So this is the actually device that we can close the atrial septal defect, and this is the way how easily we close the atrial septal defect. This is the atrial septal secundum type, and this is the right atrium, this is the left atrium, and how this is the closure device, and with this closure device usually we close the atrial septal defect. This is the Amplatzer septal occluder. This is called Amplatzer septal, and this is really usually used in case of secondum type actually. And in case of primum type, ASD primum, this is surgical treatment is the main option, and it is the only option. And in case of sinus venosus type superior or inferior, the surgical treatment or surgical correction is the option. And when there is a large shunt, when it's a big ASD, usually we advise the patient to close in the early childhood, that is early childhood around 3 to 5 years. As in the case of large shunt or large ASD, usually pulmonary hypertension develops rapidly. So this is the lecture today, I think. This is the end of this lecture of ASD. So if we summarize the ASD atrial septal defect, so what are the things usually we should know about? We should know what may be the causes of atrial septal defect, and what are the types of atrial septal defect, how the atrial septal defect usually presents, and what is the how atrial septal defect diagnosed by investigations or confirm the atrial septal defect, and how ASD usually treats, and this treatment usually depends on the type of ASD. So I think this is the end of the lecture today. So if you have any questions, you can write in the actually Facebook page where the lecture is usually running. So thank you very much for patient sharing today. And though the lecture is today actually short, only atrial septal defect is usually we discussed discussed today. So thank you very much. So thank you.